Good morning, good afternoon, good evening, maybe good night. Dear colleagues, I want to welcome you to the second day of the Global Virtual Summit on behalf of the Professor Dr. Nuri Özgürgin. I am the scientific secretary of the meeting, Fazıl Ardec. Yesterday, we have 3,200 audiences, registered audiences in the meeting from 80 different countries. I hope today is more successful meeting, and I want to invite Professor Dr. Levent Senneroğlu for the first session of the meeting. Senneroğlu, your turn.
Thank you very much, Dr. Ardec. Welcome to the second day of the meeting. I'm Professor Senneroğlu from Hacettepe University, Ankara. Before I begin, I would like to congratulate Dr. Özgürgin and the organization committee, because in these days of COVID, to transmit this meeting to 3,000 people, I think is a big success. And I'm very happy to be part of this. Before I introduce the first speaker, I would like to remind you that you can send your questions through the web page, and at the end of each talk, I would like to provide the questions to the presenter and have his answer. So the first talk is by Professor Arati Hori. He's in the Department of Otolaryngology, Niigata University in Japan. His expertise in neurotology. His talk is about persistent postural perceptual dizziness. Professor Hori, please.
Yeah, thank you. Today, I would like to talk about the persistent postural perceptual dizziness. This slide shows the history to PPPD. In 1870s, these German doctors firstly described the vertigo in a plaza and fear in a plaza. And finally, it was named as the famous agoraphobia. Now, the term of agoraphobia is mainly used in the category of anxiety disorders, and the psychiatric aspect rather than the physical aspects are emphasized. But it actually started with the physical symptoms, namely vertigo. More than 100 years later, these disorders showing chronic persistent dizziness or unsteadiness were separately proposed. Phobic postural vertigo is seen in the obsession people, which is induced by the upright position. Later, space motion discomfort is reported, which is seen in the anxious people, and the symptoms is motion or visually induced. The visual vertigo is typically preceded by the acute diseases, and the symptoms is induced by the visual stimulation. And finally, chronic subjective dizziness was proposed, and the symptoms was induced by the motion and the visual stimulation. There is a question. Are these same diseases with different emphasis of aspects? To answer these questions, the behavioral committee of the VAI Society started to discuss this issue. There are all 4 members who proposed these 4 diseases, and psychosomatic professor and I got together to discuss this issue. In 2017, the diagnostic criteria for PPPD has been published in the Journal of Vestibular Research. And the next year, PPPD was included in the WHO ICD-11, which shows the chronic vestibular syndrome. And to our recent dizziness database, PPPD was the most frequently seen among the chronic dizziness lasting for more than 3 months, indicating that PPPD is not a rare disease but a common disease. This slide shows the brief definition of PPPD. The vestibular symptoms lasting more than 3 months, and the vestibular symptoms are exacerbated by upright posture walking, active or passive movement, and exposure to moving or complex visual stimuli. The core symptoms are dizziness and steadiness or non-spinning vertigo. And the precipitating acute vestibular episode can be identified in most cases, and the symptoms cannot be not better accounted for by another disease or disorder. And these are examples of the complex visual pattern. This is also the visual complex pattern. And this visual stimulation usually induces the dizziness in PPPD patients. Regarding the characteristic exacerbation by visual stimuli and motion in PPPD, once the vestibular function is disturbed by the precipitating acute vestibular disorders, the postural control is usually shifted to the visual or somatosensory dependence. After the recovery from acute vestibular disorders, these shifts usually return to the normal balance, but in PPPD patients, visual and somatosensory dependence is prolonged. In other words, maladaptation or hypersensitization induces the exacerbation by visual stimuli and motion. This slide shows the laboratory findings in PPPD patients in our university. As same as the other dizziness, PPPD is also female dominant. The median age was 47 years, indicating that the patient is relatively young. And the CP%, mean of CP% is 19%, and any type of nystagmus was seen in 7.5% of patients, perhaps due to comorbid vestibular diseases. Visual suppression is good. VOR gain by the rotatory chair test or V-hit gain are all normal. And the HAS total score was not different from other chronic dizziness, indicating that the PPPD is not a psychogenic dizziness. And DHI total was higher than undifferentiated dizziness. And the rainbow on rubber shows the high visual dependence in the postural control, while the rubber ratio in eyes closed showed the normal somatosensory dependence. Subjective visual vertical was beyond normal range. However, in total, there are no specific laboratory findings to the TPPD. Because no specific laboratory test for PPPD is available, precise assessment of symptoms, exacerbating factors, and medical history is important for the diagnosis of PPPD. And therefore, we developed the Niigata PPPD questionnaire, NPQ, for diagnosis, screening, and evaluation of treatments. And this slide shows the NPQ. And there are 4 questions each for 3 exacerbating factors, and the answer is scored from 0 to 6. Therefore, the total scores range from 0 to 84. I will show you the NPQ. The purpose of the questionnaire is to identify difficulties in daily life that you may experience due to business. Please indicate your answer by circling the number that best describes the extent to which you have been affected during the past week. When you avoid performing these actions, you should circle the number 6. Question 1 is quick movements such as standing up or turning your head. This question is the movement factor. Question 2 is looking at large store displays. This is a visual stimulation factor. Question 3, walking at your natural space. This is an upright and walking factor. Question 4, watching TV or movies with intense movement. This is a visual stimulation factor. Riding a car, bus, or train. This is a movement factor. Question 6, sitting upright in a seat without back and arm support. This is an upright walking factor. Question 7, standing without touching fixed objects. This is also upright walking factors. Question 8, watching a scroll screen on PC or smartphone. This is a visual stimulation factor. Question 9, performing activities such as housework or light exercise. This is a movement factor. Question 10, reading small letters in a book or newspaper. This is a visual stimulation factor. Question 11, striving at a rapid pace. This is an upright walking factor. The final question, riding an elevator or escalator. This is a movement factor. Regarding the reliability of the questionnaire, Cronbach's alpha coefficient was calculated, and they were about 0.8, except for the movement score, suggesting that most of the factors of the NPQ were highly reliable with high internal consistency. This slide shows the ROC curves of the questionnaire. As indicated by this yellow line, the visual stimulation factor had the widest AUC. It was 0.83 among 3 exacerbating factors, suggesting that the visual exacerbation is most characteristic in PPPD. 9 of visual stimulation factor points had the best combination of sensitivity and specificity, and they were 0.82 and 0.74 respectively. Regarding the differential diagnosis, dizziness or vestibular symptoms can be classified into acute, episodic, or chronic diseases. PPPD is, of course, a chronic disease. Therefore, these diseases are the differential diagnosis of PPPD. Key features of PPPD, exacerbation by visual stimulation, may be most helpful for diagnosing PPPD. Regarding the treatment of PPPD, although there are no RCT studies available, efficacy of SSRI or SNRI was reported to be 50 to 70%, while it has adverse events approximately at 24%. Efficacy of vestibular rehabilitation and cognitive behavioral therapy are reported. However, at this moment, no standardized treatment strategy is available. In summary, PPPD shows persistent no vertiginous dizziness, steadiness, or both, lasting 3 months or more. Affected individuals feel worse when upright, exposed to moving or complex visual stimuli, and during active or passive head motion. Typically, the disorder follows occurrences of acute or episodic vestibular or balance-related problems. The negative PPPD questionnaire shows high reliability and validity in diagnosing PPPD. The visual stimulation factor may be the most characteristic among the three exacerbating factors. Thank you for your attention.
Dr. Hori, thank you very much for your presentation. We have a couple of questions. The first one is, can you hear my voice?
Yes.
Yeah. How to differentiate between visual vertigo and space motion discomfort, and which acute vestibular diseases are usually followed by visual vertigo?
The visual vertigo is induced by the visual stimulation, of course, but the PPPD is induced by both visual stimuli, motion stimuli, and upright position. All of these factors should trigger the vestibular symptoms. This is a difference from the PPPD from visual vertigo or space motion discomfort. And in most typical precipitating acute vestibular diseases are the BPPD. The BPPD is most frequently seen precipitating acute vestibular disorders, which falls PPPD. Okay.
Another question from Dr. Rohiwal, India. Role of virtual rehabilitation in PPPD?
Vestibular rehabilitation. Yeah.
Virtual rehabilitation.
Vestibular rehabilitation is reported to be effective for the PPPD, but the mechanisms are not clear because in most cases, PPPD patients have the almost normal vestibular function and don't have any vestibular dysfunction. I think it's true really improvement of the vestibular function, but rather it has some effects of the tolerance or exposure to the vestibular, to the exacerbating factors, because the PPPD patients will become tolerant during the vestibular therapy. Therefore, it's a kind of exposure to the exacerbating factor during vestibular rehabilitation. Right.
One question from Philippines, Nathaniel Young. Are there specific vestibular conditions such as Meniere's disease, superior semicircular canal dehiscence, which are more likely to be associated with the development of PPPD?
Answer again, please.
Are there specific vestibular conditions such as Meniere's or superior semicircular canal dehiscence, which are more likely to be associated with the development of PPPD?
Semicircular canal dehiscence or Meniere usually associated with, but it's not the major diseases. I think that the precipitating diseases, the most frequent one is BPPD, and the association is seen in almost all vestibular diseases. The Meniere is usually seen, and SCD is seen, but it's not so specific. We do not need to be specific to the association of the vestibular diseases.
Professor Hori, thank you very much for your excellent presentation and questions. We move on to Daniel Kaplan. The second presenter will not be available for his talk. Professor Kaplan is the chief of Department of Laryngology of Soroka University, Beersheba, Israel. He is also the director of the CI program in the same university. His special interest in vestibular testing and BPPV, and he is going to talk about BPPV. Professor Kaplan.
Thank you very much, Levent, Professor Ardik, Professor Özgürgün, for this amazing opportunity. I would like to, I'll just move to my screen. Can you hear me? What I would like to talk about is a little bit beyond the regular posterior canal BPPV. Just a moment, this is in my way a bit. So what I want to talk about in the next 10 to 15 minutes is about unusual presentations of BPPV arising from the posterior semicircular canal. And so this is a message I put on my Facebook. I'm really very proud to be a part of this project. And just talk about conflict of interest. There's none. Some of the material I'm presenting here has been previously presented, but this is after having them published and more, I would say, more mature. So the main presentation will be here about the significance of BPPV arising from the posterior semicircular canal during the roll test. This was recently published in Hebrew in our local journal, a special issue in otolaryngology in February 2020, and with some of my colleagues here. And let's get down to it. So we have the guidelines of the American Academy in 2008 and 2018 that talk about the different aspects of BPPV, with, of course, emphasis on the posterior canal, which is the most common one. And what they write, especially in 2008, if I'm not mistaken, they repeat it, is that if the patient has a history with BPPV and the Dix-Hallpike is normal, one should perform the roll test or send him to someone else who knows how to do it and look for other types of BPPV, looking at, of course, looking mostly at the horizontal canal. So when we perform a roll test, what are we, just to sort of remind you guys, we are actually looking for the diagnosis of horizontal BPPV, and typically it will have a horizontal bidirectional nystagmus, more on the affected side. It'll be geotropic, going to the downmost ear, which is canal lithiasis, and on a more rare occasion, agiogropic, going the other way, will be signifying cupulolithiasis. The patient will naturally be symptomatic when you're putting him down on the symptomatic signs. From 2009, actually till today, we continue doing a standardized positional testing for all types of BPPV. The idea was not to miss any type of BPPV. We started actually with a roll test for horizontal canal BPPV, and then performed the Dix-Hallpike, of course, the posterior and anterior canal BPPV. And later, which is not a part of this work, is if the Dix-Hallpike was negative, we performed a Dix-Hallpike while shaking the head, which, as I will show later, brought some extra yield, but that's not a part of this study. So if the patient was positive, he had a modified Epley maneuver, repeated Epley maneuver until he was non-symptomatic or had no nystagmus, and follow-up visit every 2 weeks until cured. Cured means no nystagmus and asymptomatic. In most cases, it took about 1 to 3 Epley maneuvers in each visit. And of course, as far as visits, usually 1 to 2 visits sorted it out. So while we're performing the roll test, what we found was something we were not actually expecting. We found some patients had the unilateral torsional geotropic, which was not horizontal, symptomatic, lasting for seconds. This sort of reminds us of the classic BPPV in the Dix-Hallpike position. So then we took the patient and positioned him or her in the Dix-Hallpike position, and then we find that the nystagmus gets actually quite a bit stronger, intensifies, and Actually, this is why we would imagine this is a BPPV. However, as I said, posterior canal which is presenting on the roll test already and intensifying on the Dix-Hallpike test. This is just a short video. You can see what's happening when we turn the patient to the left. This is not a Dix-Hallpike. This is the roll test, and look at her eyes. This is the typical nystagmus you would expect seeing in when you're positioning the patient in Dix-Hallpike. But again, as we saw here, and I will show again, this patient is lying in the roll test. She's lying down supine and is symptomatic. When we put her in the Dix-Hallpike, it got worse. So what is this strange finding? In our study, what we wanted to do is to compare the patients who had the regular BPPV only in the Dix-Hallpike position and those who had this phenomenon of classic BPPV. However, it's in the roll test position. So group 1 was the classic group, and group 2 was patients with torsional nystagmus and symptoms on the roll test. So we examined consecutive patients during a period, inclusion of all these consecutive patients, exclusion patients who eventually had, on diagnosis, had other types of BPPV, and patients who did not complete the follow-up visits in the clinic until cured.
Dr. Kaplan, can you arrange your camera a little bit to see your face?
Thank you. Okay, so we had 102 patients. Most of them were in the study groups, and we had the exclusion ones, no follow-up visits or bilateral BPPV, and who had horizontal BPPV, who were excluded here. And if we look at this group, it's not a large group of patients. We had 69 patients in group 1 with a classic BPPV and 22 patients who had it only on the roll test. Comparing the findings here, interestingly, what we can see is the age was quite similar, average 59, male to female. Interestingly, many more females in the regular group. 78% were female, as opposed to 55%, almost half and half in the regular group. Symptom duration, a large difference. The one in the classic group had much longer symptoms, 43 days on average, while the ones who had the BPPV already on the roll test had a much shorter duration of 22 days only. The number of visits until the number of visits until recovery was quite similar. The percent of patients cured after one visit was quite similar. An interesting look here, looking here at what happened in this first visit. We repeat the epley until the patient feels better and hasn't had nystagmus. And look over here, you can see in the classic group, in 77%, one epley maneuver was enough, and in 23%, only one was enough in this roll test. In other words, they needed more. The ones who were positive in the roll test needed more therapy. Now, if we want to look at these and try and interpret these findings, the male-female difference is really very, very strange. We'd expect it to be quite similar. Perhaps the reason for this is just probably chance because of a small series. Although this is significantly clear, the numbers are not so great here. Otherwise, I do not have a clear explanation. Looking at the symptom duration, as I showed you, the duration of symptoms were much shorter in the group who were positive on the roll test. And this brings to question, perhaps they were more symptomatic, they were maybe referred faster. The patient also felt worse and referred himself or herself much faster. Perhaps group 1 had partially recovered too, because they had supposedly a lighter version of the disease. And the third issue was the percent of patients that were one epley maneuver was enough for them was much lower in the group positive on BPPV, and that brings us to think that maybe perhaps there's more resistant or more severe disease, the ones who have it already on the roll test. The other issues were no difference, number of visits, and percent of patients with cure after one. And this brings us to ask, why do we see it on the roll test? Well, the mechanism is replacing the head in the roll position still causes debris to move amplifugally in the posterior canal, but lesser extent than the typical Dix-Hallpike. And you can see over here, if I'm positioning the patient in the classic Dix-Hallpike, this will be the vector. and in the roll test, it'll be 45 degrees more to the side. And if you look, you can see, I'm just going to move this a second so I can see, still debris will move. So actually what's happening is it's quite similar to what's happening with the patient's daily life. The patient who has positive BPV many times, it does not position himself in the Dix Hall pike, but rather moves the head to the side, which is very much what happens on the roll test. So this is a lower stimuli causing movement of debris, but still causing in some of the patients this phenomenon of torsional geotropic nystagmus. So although it's weaker, it's still a response to stimuli of the posterior canal cupola and roll test. So conclusions of this part, we should recognize this form of VPPV on roll test, which identifies on Dix Hall pike and is different. It's actually quite different from the horizontal VPPV. Patients in group 2, the positive roll, seem to have a more severe form of VPPV. However, they respond very well to the Epley maneuver and have a similar outcome on the whole. So they may have a different curve, but eventually they reach the cure faster. And the last point was, since we performed here roll tests before BPPV, we were getting these findings. However, they probably don't have any significance. If you do a Dix Hall pike first, you will not, of course, see this finding. I would just like to refer very briefly in the next couple of minutes to some previous work of ours that was published in the Otology and Neurotology in 2014. And this was looking at the roll test, looking at Dix Hall pike exam. Patients who were negative also went through a Dix Hall pike with shaking the head. And this actually increased the diagnostic yield, as we showed in this paper, that 12 additional patients had from a negative Dix Hall pike while shaking their head became positive. So actually the conclusion was that we could increase the diagnostic yield of VPV from 69 to 81% if patients were negative. So this is an important sort of tip. So shaking the head during the Dix Hall pike increases diagnostic yield and should be performed when the Dix Hall pike is normal. And this is sort of a summary, some thoughts about BPPV. You can have a very sort of robust, very, I would say, strong BPPV, which is already seen on the roll test, as I've seen. I'm sorry for the typo here. You could have the classic BPPV just on Dix Hall pike. You could have BPPV only when you're shaking the head, as I showed previously. And as you probably know, there are many papers on the issue of subjective BPPV. In other words, you examine the patient, there's no finding, however, he's symptomatic, he or she is symptomatic on Dix Hall pike, but the eye movements are normal. So we think sometimes that's maybe something already under therapy, which is already improving. And of course, vertigo of other diagnosis or recovery for BPPV. The patient isn't symptomatic and has no findings. So I'd like to thank you for your kind attention. I'll be happy to answer any questions that I might be able to.
Dr. Kaplan, thank you very much for this excellent presentation and also keeping on time. I have a couple of questions to you. One from Dr. Güneri, Turkey. Do you think that stimulation of the ipsilateral posterior semicircular canal during the roll test may be due to different angle of attachment of the posterior semicircular canal cupula?
Well, that's a very interesting question. We know about gross anatomical differences that maybe make patients more prone for BPPV. There's been some studies on MRI on the position of the semicircular canals. But this question is arising, are there structural microstructures that may make a difference and may make these different presentations of BPPV? I have no idea. That would be an exciting thing to examine. The big problem is, of course, that we need a PM. So you have a patient who just has some vertigo. I don't think it would be a very good idea to check histology, but it's very interesting. It's just going to be very difficult to examine.
Yeah. One other question from India, Dr. Rohiwal. Interval at which repeated Epley maneuvers was done. What is the interval for Epley maneuvers?
I'm not sure I quite understood. During the visit, what we do is, it's quite accustomed in the literature that if the Epley maneuver is negative, you do an Epley maneuver and you re-examine the patient. And if the patient still has BPPV, you will repeat it. We usually don't do more than 2 or 3 because it's very uncomfortable for the patient. What I do is I wait a few minutes. The patient sort of recovers, gathers one's breath, and we re-perform the Dix-Hallpike, and if it's positive, we immediately do an Epley again. We feel that it's probably useful, but I think there's very few studies have really shown it.
I think he asks the interval when the next time you will repeat the test.
I'm sorry. I wrote in the protocol. I call the patient in 2 weeks later, and ask the patient, of course, lie down with their head 30 degrees, 2 pillows, perhaps use a neck, what do you call it, bracelet or something if one wants to. So it's 2 weeks.
One final question, Dr. Kaplan.
Yeah.
If variations in canal anatomy could be responsible for rho-positive posterior BPPV?
I think that's very similar to the first question. So my guess is probably could be, but again, it's going to be hard to test.
Okay, thank you very much, Dr. Kaplan.
Thank you very much.
We move to the next presenter, who is Dr. Bans. He's professor of otology and skull base in University of Cambridge. He is dealing with vertigo for 25 years, particular interest in hyperventilation and dizziness, and home testing, which I think is must be very popular right now. And his talk is about the comorbidities in vestibular system. Professor Bans, please.
Thank you very much. Can you hear me okay?
Fantastic. Thank you.
Very good. Thank you to Professor Ozgerden and I think for putting this fantastic program. Very much appreciated all over the world. So I want to talk about some of the comorbidities in dizziness. I have no conflicts of interest to declare. This is kind of a follow-up to my last talk in Belarus, where I talked a little bit about hyperventilation, which I'll cover again a little bit just as a recap. But since then, we've looked at more of the other comorbidities in this population we're looking at, and these particularly looking at things like anxiety and depression. And so we've had a chance to analyze those and recently published those. So I wanted to bring an update to that. Okay, something is, okay, oh, sorry. So what I'm going to talk about is our experience in the vestibular assessment clinics in Cambridge University hospitals by the vestibular therapists. So these are the patients who, and we looked at their results from various questionnaires. I looked at some comorbidities, and I'm going to focus on 2 things that can co-occur with dizziness. One is the hyperventilation. This is more of a recap from my last talk. But the new stuff that we looked at this time around was anxiety and depression. So the hyperventilation, I mean, there's 2 really parts to it. So there's 2 real components to hyperventilation. One is the hyperventilation unmasking true vestibular disease. The other is hyperventilation as a cause of dizziness per se, without vestibular disease necessarily. Hyperventilation is a very complicated stimulus. I'm not sure if you can see my mouse, but it affects many different parts of the vestibular organ. It can affect the middle ear pressures. It changes calcium levels inside the inner ear. It can change conduction through the 8th nerve. So if it's partially demyelinating, lets it conduct again. So it's a good test for retrocochlear pathology. It reduces blood pressure. It can interact with dysautonomias. It reduces blood supply to the brain through cerebral mechanisms, autoregulation mechanisms, and the thoracic stretch receptors, just by the breathing, can trigger anxiety and panic attacks. So it's a very complicated stimulus, works at many different levels. Many years ago, in 1998, I think we were the first to describe that vestibular disease could be unmasked by taking a bunch of patients with acoustic neuromas, showing that most of them got nystagmus towards the side of the tumor when we hyperventilate them. This is a quick video to show somebody with a petrous apex granuloma. Most of these patients have retrocochlear pathology who are positive. This just shows somebody with, I'm just quickly going to go through this, fast forward. There's a petrous apex granuloma. And as we start to hyperventilate, initially no nystagmus at rest, and after about 30-40 seconds of hyperventilation, we start to see the unmasking, this torsional horizontal beating nystagmus towards the side of the lesion. And this happens not infrequently with retrocochlear pathology. And a follow-up study we did way back then showed that it is much more common in retrocochlear pathologies such as acoustic aroma than end organ disease, such as Meniere's disease. And it's also frequently positive vestibular neuritis or vestibular neuritis as well. Anyway, but I'm more going to focus on hyperventilation syndrome as a component of anxiety and dizziness. And I have to thank these two people who did a lot of the work on this in this cohort of patients. So we know that patients who present to anxiety clinics or panic disorder clinics do present a lot of symptoms that we would also see in the dizziness clinic. For instance, these are patients presenting to a panic disorders clinic, and they're in between symptoms. They present with dizziness, feeling of falling, spinning, and a tendency to fall. So quite a large percentage of these patients are presenting to these panic disorder clinics are complaining of symptoms that we sometimes hear as well. Hyperventilation syndrome is not well defined, but has been defined as your ventilation needs exceeding your metabolic needs. Mostly it's been defined in the context of asthma and respiratory disorders, because some of these patients do also have additional panic disorders on top of that. And there's different groups of symptoms. One is a respiratory, breathlessness, tightness, tetanic symptoms from the low calcium, that means trembling, tingling, etc. Cerebral symptoms, dizziness, cardiac symptoms, palpitations, tachycardia, temperature symptoms, cold hand, GI symptoms, and the general symptoms of tension, anxiety, fatigue, etc. The way we looked at it was through this hyperventilation questionnaire from Nijmegen, the Nijmegen questionnaire, which asked for a lot of these symptoms. It really is focused on, it was validated in asthma patients originally, so it's really focused on these symptoms of hyperventilation. And only one of the questions is about dizzy spells, and a score of 23 and above is considered positive. So we looked at these 359 patients in 2017. We found almost 40% scored positive on this hyperventilation questionnaire. And interestingly, we had done the same study back in 2000, about almost 20 years ago, and back then only 23% had scored positive, so more seemed to be becoming positive with time. And it was interesting that those who had peripheral vestibular lesions had the same average scores as those with other diagnoses. So it wasn't that the ones with true vestibular lesions on caloric testing were more positive or less positive. It seemed to be spread out amongst the whole population. Now, our vestibular therapists don't take the diagnosis just from the questionnaire. They do their own in-depth interpretation by talking to the patient, measuring their breathing rate, etc. And they come up with a clinical diagnosis, what they think, those patients they think have hyperventilation disorder. And of the 159 scored positive, they only thought 34 actually had hyperventilation disorder. And so that, but the questionnaire picked up 70% of them. But there was a high false positive rate in their minds, and that a lot of these patients who scored positive, they didn't think had true hyperventilation syndrome. But we don't know because there's no gold standard. So this is a clinical judgment, and they're undercalling it rather than, and maybe the questionnaire is actually more correct in calling the true prevalence. So in asthma clinics, the sensitivity has been diagnosed to be 80–90%. So this was a big amount of work by Chris Williams, one of the medical students. So these patients, when they were talking, so this is now not a questionnaire, this is what they were actually saying to the therapist. Usually it's written down almost verbatim. So he went through thousands of words that these patients said, and he mapped them to his natural language processing engine. And then you have to map them one of these words that's in the metamap. So these are volunteered words, not what they said in the questionnaire, but these are what they've actually said when they were talking. When you look at those who are positive in Nijmegen questionnaire versus those who are negative, they didn't say vertigo more often or dizziness more often, but a little bit more often. But the things they said much more often were blurred vision, shortness of breath, chest tightness, and sensation of panic. So look out for these trigger words. If you hear these words, volunteer, start thinking about there might be an underlying hyperventilation disorder. This falls into a pattern of possible breathing disorders where the people have described air hunger, sighing. You can sometimes see the patients, they're sighing, they're yawning, they're breathing very fast, etc. And I'm not going to go into the breathing exercises, but often these patients are given breathing exercises in my experience, they don't work that well unless they a couple of other things like psychological therapy, etc., lifestyle changes. But maybe that we're not doing them correctly. But I find the breathing disorders booklet by itself doesn't really cause a big change in a lot of these patients. So now onto the new stuff that we had also looked at, which was the hospital anxiety and depression scale, the HADS questionnaire. This is a very well documented and validated questionnaire looking at anxiety and depression. 14 items, 7 for anxiety and 7 for depression. And a score of greater than 11 in either category is considered moderate to severe anxiety and moderate to severe depression. So we looked at these scores for anxiety and depression. So those patients who scored more than 11, would be diagnosed as moderate to severe anxiety or depression against a diagnosis made in the clinic. And when you look at these patients, a lot more people have anxiety than have depression on the scores. Overall, about 30% of the patients in the questionnaire would be diagnosed as having moderate to severe anxiety, which is a very large number. And if you look at it by diagnosis, those people who had multiple diagnoses and we couldn't really tell what was going on, to be honest, they had scored the highest. They also had high depression scores, but not as high as anxiety. Psychogenic dizziness, Meniere's disease scored high both on anxiety and on depression, but also vestibular migraine, BPB, and others. Interestingly, things like labyrinthitis and CP angle tumors weren't particularly anxious or depressed. So when we so the thing that I really want to point out is that we as clinicians failed here in that even though we had this data, we only referred 13% of the positive patient anxiety disorders for treatment to the GPs. Only 16% of those were positive for depression to the GPs for treatment. So we as a clinician group are failing to get these patients treated for the underlying disorders. When you map this on a scale where you put the depression index on one side and anxiety index along the bottom, the blue line represents the identity line, so they were exactly equal scores of depression and anxiety. We see that most people fall more towards the anxiety side, so there's a lot more anxiety than depression. But look, multiple diagnosis gets high in both. Meniere's surprised me that these patients tend to have a lot of anxiety and a lot of depression compared to other diagnoses, such as CP angle tumors and vestibular migraine, for instance. So this is a sort of a map, and this has been published just recently in Clinical Otolaryngology. There was some interaction between the Nijmegen question, anxiety and depression. Those people who had anxiety and depression were more likely to score positive on the hyperventilation questionnaire as well. So there is some interaction between those two. So really, I want to the new data that we have just brings out again the complex interplay between the many factors that these patients come into our clinics. There's the vestibular lesions, the breathing disorders, anxiety, depression. I think some of them have dysautonomia, the visual aspects of PPPD, and these all bring out these complex, really difficult interplay between the psychological state, which can be a result and a cause of the dizziness. As conclusions, hyperventilation can unmask vestibular disease, particularly retrocochlear disease, and can be used as a bedside test. If it's positive, suspect retrocochlear pathology. A lot of patients, about 30% have a hyperventilation type background, and look for trigger words when they're talking to you, such as sensation of shortness of breath, the sense of panic behaviors such as breath holding or rapid breathing when they're talking to you. Hyperventilation syndrome is associated with depressing anxiety, but is not more common whether you have true vestibular disease or not. It's present most equally in those with and without true vestibular findings and caloric testing. Many vestibular disorders, this is the main finding I want to point out, many vestibular disorders are associated with high levels of anxiety and depression, and these are easily missed. And I'd put my hand up and say we've been very bad at referring these patients for therapy. And think about enrolling help from mental health professionals more often in some of these patients. Great. Thank you very much.
Professor Benz, thank you very much for this presentation and also keeping on time. I have a couple of questions to you. The first question from Dr. Kasat from India. What could be the cause of direction changing nystagmus after hyperventilation?
Direction changing nystagmus.
Hyperventilation.
I mean, the ones that we see are usually irritative towards the side of the tumor, or or paralytic when you've had a tumor removed. So the irritative side is usually because there's a partially demyelinated segment of the 8th nerve, and we know that hyperventilation drops the ionized calcium, which makes that part conductive. So you've had a lesion that's not been functioning, and you've been centrally compensated at the brainstem. All of a sudden, it starts functioning because you start getting afferent activity. So it looks like an irritative lesion. It beats to that side. When you have a paralytic lesion, such as post-op Christian patients, we find that it always beats towards, in a paralytic way, always beats towards the side that was removed. So that's usually, we think it disrupts compensation mechanisms. Direction changing, I only saw 1 or 2 patients who had direction changing nystagmus in the whole 100 that we did in that series that we hyperventilated. And I'm not sure about the mechanism of direction change. I think there was only 1 who had direction changing in the whole of that group.
Thank you. The second question is from Dr. Sumit Dasgupta from UK. He's asking if you observe this hyperventilation in multiple sclerosis or any demyelinating lesion.
Demyelinating lesion. Well, I haven't done a study on those patients, but hyperventilation has been studied in multiple sclerosis, and it reduces scotoma size, for instance. So it can reduce the size of the scotoma from the optic neuritis. So it does improve optic transmission. Most of the time, I would imagine that the lesion in MS is not in the nerve. It's going to be in the brainstem nuclei, and I'm not sure what the effect there would be. We know the optic nerve is actually lesions in the nerve itself. In the vestibular system, it's probably more likely to be in the central, more in the vestibular nuclei. So I don't know what would happen in that situation, to be honest.
The third question is again from India, Dr. Porwal. What are the differential diagnoses of hyperventilation-induced nystagmus? Can it be seen in vestibular migraine patients? And what is the diagnostic sensitivity of this test? Can be seen in vestibular migraine.
So, I haven't seen the vestibular migraine, not between episodes. We've seen it in retrocochlear pathology like vestibular schwannoma. We had a sensitivity over 75%. So we could pick up those patients about 75% of the time who had a lesion in the 8th nerve. It's also been described in many disorders like superior canal dehiscence, for instance. It's been described in neuritis in about 60% of patients with vestibular neuritis. Vestibular migraine, I have not. No, I don't even. No, I don't think I've seen it in between attacks. Vestibular migraine have been positive.
And one final question. Another doctor from India, Dr. Dutta, is asking, what is the pathophysiology behind hyperventilation resulting in dizzy spells?
Well, that's like I said, that's there's many possible mechanisms. So if you have a demyelinated segment, then it will cause it to start working. So if you truly have a vestibular disorder, retrocochlear, it will that's a mechanism because it let that vestibular conduct again. If you don't have that, there's so many other reasons why it might cause dizziness. It drops the brain blood flow by 50%. It drops systemic blood pressure. It also affects it can trigger panic anxiety disorders through the stretch receptors in the thorax. It drops inner ear calcium. It could change middle ear pressure. It does so many things to different parts of the body. So it's very hard to know what the mechanism.
Yalınay Dikmen from Turkey. She is a professor of neurology at Acıbadem University in Istanbul. She's a fellow in European Board of Neurology. She has MS degree in neurophysiology, and her interest is in headache and vestibular disorders. Her talk is about vertebrobasilar insufficiency. Dr. Dikmen, please.
Hello from Istanbul, my colleagues. I'm honored to be part of this virtual congress in Worldwide. Today, my topic is vertebrobasilar insufficiency, VAI in short. VBI is transient ischemic attack of posterior circulation of brain. VBI presents with sudden onset. All neurological signs and symptoms are transient and related to posterior circulation of brain. And these symptoms have resolved within 24 hours, usually last up to an hour, and there is no any evidence of acute infarction on radiological imaging. VBI is a major warning sign before stroke. When a patient presents with isolated vertigo or dizziness in ER or clinical setting, compared to brainstem sign and symptoms, it is more challenging because VBI should be differentiated from benign etiologies vertigo. VBI should not be overlooked because VBI in these patients have a higher risk of stroke within 3 months, especially within 1 week following VBI. I don't have time to discuss the details of anatomy, but I should remind you that vertebrobasilar system supplies blood to very critical anatomical areas such as brainstem, thalamus, hippocampus, cerebellum, occipital and medial temporal lobe, and central and peripheral vestibular system. When a patient presents with isolated vertigo or dizziness, the affected anatomical structures are one of 3: the vestibular nucleus, or the entry zone of vestibular cochlear nerve, the labyrinth, or cerebellum, nodulus, or ovula. ICA supplies blood to an inner ear and brainstem, so ICA infarction may cause either central or peripheral vertigo. ICA supplies blood to brainstem and cerebellum, so ICA infarction causes only central vertigo. Let's take a look at history. The clinical features of VBI were described in 1946, was named VBI in 1990. Vertebrobasilar system pathologies may be present in 2 different clinical forms, either VBI or stroke. About 20% of stroke occur posterior circulation of brain. The exact prevalence of VBI is unknown because a diagnosis of VBI is mostly based on patient's history and is made retrospectively. A study showed that 12 to 18% of patients with posterior stroke have had VBI previous to stroke. Etiologies of VBI are summarized in this slide. Large artery atherosclerosis and cardioembolism are the most common reasons in elderly patients, whereas vertebral artery dissection is the most common cause in younger patients. In pathophysiology, there are 2 main reasons. First one, hemodynamic failure in VB system due to basilar artery stenosis or severe bilateral vertebral artery stenosis or dominant unilateral vertebral artery stenosis when the contralateral side is congenitally hypoplastic, or cardiac arrhythmia due to it causes systemic hypoperfusion. The second reason is artery-to-artery embolism from ulcerated plaque in vertebral-basilar system due to trauma, vertebral artery dissection, or compression. In which patients we should consider a diagnosis of VVI? Primarily, elderly patients have a history of stroke or stroke risk factors, such as hypertension, diabetes, hyperlipidemia, cigarette smoking, etc. Taking history from patients, a trauma should be questioned because of vertebral artery dissection diagnosis. And blood pressure should be measured from both arms of patients to define subclavian steal syndrome. A cardiac examination should be underdone in those patients because of detect arrhythmia and systemic hypoperfusion. VVI may present with vertigo or dizziness. It may present focal or non-focal neurological signs and symptoms. Drop attacks are very important in elderly patients. They may cause serious injuries. Headache, vomiting, cranial nerve signs, diplopia, dysprasia, dysarthria may happen. Visual disturbances, ataxia, imbalance, confusion, motor and sensory disturbances may happen. But they are episodic and transitory. So when you see the patients, you may not see nothing. And patient's neurological examination might be normal. A history of VVI usually made on a diagnosis of VVI usually based on patient's history. A study showed that patients in ER presenting with vestibular symptoms, they were finally diagnosed with stroke. They were initially misdiagnosed. So if patients have multiple stroke risk factors and sudden onset, long duration vertigo, these make VVI diagnosis very likely. In neurological examination, when you see the patients, patient's neurological examination might be normal. But if you see a brainstem or cerebellar sign or cranial nerve abnormalities, they are very helpful. Of course, hence, oculomotor, three-part oculomotor test is very important. A positive head impulse test shows either peripheral cause of vertigo or isolated ICA infarction. We should remind that. And the nature of nystagmus is very important. Vertical or direction change of nystagmus is very indicative of VVI. When we come to evaluation, first we want to rule out any acute infarction of posterior fossa or brainstem. Diffusion-weighted MRI is gold standard for that. But diffusion-weighted MRI may be false negative in 12 to 20% of patients posterior brainstem infarction within 48 hours. So repeated diffusion-weighted MRI may be needed. To define VAI diagnosis, we want to see stenosis or occlusion or dissection of vertebro-basilar system. We have three tools for that: CT or MR angiography and color Doppler sonography. CT and MR angiography have higher sensitivity compared to color Doppler sonography. Color Doppler sonography has lower reliability because it is highly dependent on operator. The normal range of vertebral artery blood flow is quite range. It changes between 100 to 300 milliliters per minute. And cutoff value of lower limit is 100 milliliters per minute. So VAI diagnosis should not base on vertebral artery blood flow. When we come to treatment, antiaggregan or anticoagulant treatment might be chosen depending on etiology. Surgical approach is very limited in this critical anatomical area. If patients has a symptomatic high-grade stenosis and a patient is resistant to medical treatment, endovascular treatment should be indicated. In conclusion, if vertigo or dizziness coexist with neurological signs and symptoms, if an etiology of vertigo or dizziness is not explained by one of the peripheral vestibular disorders, if an older patient who has stroke risk factors present with vertigo or dizziness, VAI should be suspected. Thank you for your attention.
Thank you, Dr. Dickman, for the presentation. We also have a couple of questions to you. One participant from India, Dr. Biswas, he wants to know, in both ICA and PICA strokes, the regional vestibular nucleus may be affected, but why is VHIT always negative in PICA, but sometimes positive in ICA strokes?
Because ICA supplies blood to inner ear, so positive head impulse tests relate to these anatomical differences. PICA supplies blood to only brainstem and cerebellum, but positive head impulse test shows only inner ear involvement. I hope this is your answer.
Okay. Do you consider cervicogenic dizziness as differential diagnosis? The question is from India, Dr. Parwal.
Sure. It's a very controversial topic, actually. VAI may be caused compression of vertebral arteries due to cervical spondylosis. It might be happen, but you need to show that on radiological imaging. You need to you need to evidence. So it might be happen, but you need to show radiologically vertebral arteries compression on cervical radiological imaging. Otherwise, I don't consider.
Okay. Can VAI present with isolated tinnitus?
Isolated tinnitus. Isolated tinnitus might be happen, isolated ICA infection. I guess in the literature, only maybe 10% of ICA infection present with isolated tinnitus. But ICA infection very rare actually. So 10% of ICA infection is more rarer. It might be happen, but very seldom case.
Okay, there's a question from Turkey, Dr. Balkan. Is there a sign of VBI during VAHIT since there is a sign in head rest test?
Could you say again? I didn't understand.
Is there a sign of VBI during VAHIT since there is a sign in head thrust test?
VBI can be used in head thrust test might be used VBI diagnosis. Is it the question? VBI?
No, is there a sign of VBI during VAHIT?
I can't hear you. I'm so sorry.
Okay.
VBI head thrust test is very helpful bedside test. We should do all time to differentiate peripheral and central reason of vertigo. And VBI is a central one of central vertigo. So head thrust test can be positive in VBI in case if ICA infarction, in ICA territory involvement, just that. Otherwise, no.
Final question. There is a question from India, Dr. Singh. How do you differentiate peripheral vestibular lesion and isolated ICA infarction?
It is clinically, it is hard to differentiate. You need to do radiological imaging, and I said that earlier, sometimes the fusion-weighted MRI, it's the gold standard to show acute infarction. Sometimes within first 48 hours might be false negative, almost 12 to 20% of patients. So you need to do repeated MRI, diffusion-weighted MRI, to see ICA infarction or small brainstem infarction. You need MRI to differentiate that. Clinically, it is hard to do that, just clinically.
Dr. Dickman, thank you very much for the presentation and answers. We come now to the final presenter, Dr. Leonardo Manzari. He is the head of the MSA ENT Academy Center in Cassino, Italy, lecturer in otoneurology, vestibular medicine and rehabilitation for master students in the University of Pisa, and his talk is about vestibular neuritis. Dr. Manzari, please.
Thank you, Professor Seneroglu. Thank you, dear friend, and it's an honor to me to be there in this outstanding meeting. Many greetings from not a sunny Italy, but a Cassino under the rain, and I will talk about vestibular neuritis and. Many thanks to my friend Nuri and all the organizing committee for this kind invitation. So, when a patient arrives at the clinic with an acute attack of long-lasting vertigo, a major question facing the clinician is what caused this attack? The question is very important since in my mind, there are a lot of possible answers. Is due to a vestibular neuritis, or a superior vestibular neuritis, or inferior vestibular neuritis, or it is a Meniere's attack, or a pseudoneuritis. We live in a revolution time. Since in the last 10 years, probably, we have a lot of weapons to answer to those very important questions, especially at the time of the attack when we face the patient. But I like to start from these neuroanatomy images from the labyrinth, from the Burley since 1924, the best images to me of the inner ear. As you can see here, we have we have the 8th pair of the 8th cranial nerve, and the division is very clear from the superior to inferior vestibular neuritis. Since 2005, we have a lot of clinical indicator to answer the question I made in the first slide of my talk. Now we have the weapon to answer to all the questions, but above all, the basis of our work actually is that any particular part of the vestibular labyrinth can malfunction. So we can have also a selective deficit of the vestibular nerve, and this kind of intriguing new matter cause the symptoms of our patient complain about vertigo, nausea, postural unsteadiness. Since that times, calorics only test very inadequately, since it tests on the horizontal semicircular canals. Now, the new test all the 5 sensory and organ in each inner ear. But vestibular neuritis has been described as an acute episode of vertigo lasting days to weeks. Its clinical course is absent of auditory findings or any other neurological symptoms, and that is crucial. There is generally complete recovery of symptoms for most patients in the first week after the onset of the disease, whereas some patients experience lingering disequilibrium. Vestibular neuritis has generally been reported as a single severe prolonged attack of vertigo without recurrence occurring on one side. However, Schucknecht and Kitamura and Schucknecht and Will several years ago described recurrent vestibular neuritis and bilateral sequential vestibular neuritis. What is the epidemiology? Epidemiology vestibular neuritis has an incidence of approximately 3.5 per 1,000 population. In our clinic, the Cassino Clinic, vestibular neuritis is the 3rd most common cause of peripheral vestibular disorders, and the most common cause is benign paroxysmal positional vertigo, and the second one is Meniere's disease. The usual age of onset is between 30 and 60 years, and age distribution plateaus between 40 and 50 years. There is no significant sexual difference. Etiology. The etiology is unknown, but the leading has been a viral inflammatory process with herpes simplex virus involved, as Gajcek and Gajcek reported in 2012 and confirmed by Gerard Giannoli and colleague 3 years later. Well, the last weapon we use in the clinic, and we use just at the time of the attack, the last instrumental weapon, allows us to differentiate in many cases, in the most cases, in all the cases I can say now, that which part of the vestibular nerve is involved by the disease. And probably the most common part of the vestibular nerve involved is the superior part of the nerve. There is an anatomical reason, just like you can see here, since this is the inferior part of the nerve. Figure from the Giannoli paper in 2005, it's very interesting how the inferior part of the vestibular nerve is just attached to the bone, to the channel bone of the nerve itself, while the other part of the nerve, the singular nerve, this long part of the is not so attached to the bone. Very different from the superior nerve, superior part of the eighth cranial nerve, vestibular cranial nerve, when we can see how the bone is not attached to the nerve, and so this could be the reason for the viruses to reactivate itself at the time of the attack. These are two very intriguing papers to me. 10 years ago, Stroop and Brandt published this paper in seminars with, named Vestibular Neuritis, and my colleague, Michael Almaghi, Konrad Weber, Ian Courtois published another paper 1 year later, Vestibular Function after Vestibular Neuritis. Why they are so intriguing? Because if we start from the second one, Michael and colleague ask on the topic two questions. The first is, what happens if one intact labyrinth is surgically destroyed? What is the acute vestibular neuritis? This is very crucial to me, since in many papers, many of us studied, try to compare the two situations. That's not, this is not just the same, since we have a crossroad at the end of the question, where when we face a patient with unilateral iatrogenic vestibular deafferentation, is he or she totally different from a patient with vestibular neuritis, can, as we can see, can fully recover at the end of the disease, or can partial or have a residual unilateral vestibular loss. The second paper, Vestibular Neuritis, from the German colleague, I'll rise up with several questions, and my understand of this question and my concern about this question at this time are they so important as 10 years ago? Well, I try to answer in the next slides. Vestibular test until 2005, spontaneous nystagmus, calorics, head impulse test, bedside version, bucket test plus subjective visual vertigo, cervical vamp to eye conducted sound or bone conducted vibration. And now, what is changed from 2005? spontaneous nystagmus, of course, calorics, of course, but we have a video head impulse test that change a lot in our clinical activities, daily activities. Bucket test and subjective visual vertigo are still there, but we have another VAMP that allows us to complete the study of all the sensory region in the inner ear. Well, a patient with vestibular neuritis at the time of the attack, and as you can see here, the patient show us a very clear catch-up saccade when his head is turned to the left. Well, so we now we can divide now our job in two sectors. The first one is semicircular canal. The second one is the otolytic region. Obviously, the video head impulse test, this is the prototype version from Hamish McDougall in our clinic in Sydney, compared with the search coil, as you can see, allows us in this well-known position to obtain these results in the normal subject. And if we compare these results with this one, we are able now to test all the 6 semicircular canals. When we face a patient at the time of the attack of an acute left vestibular neuritis, the pattern is very clear. A shower of covert and overt saccades when the head is turned to the left. While if we are facing a patient with vestibular neuritis in toto, now we can perform this kind of test at the time of the attack, and we find that the left anterior, the lateral, and the left posterior semicircular canal are not working, while the right semicircular canal properly working. But we learn so much from the video head impulse test. Why? Why calorics are so unpleasant for our patient, especially at the time of the attack, and after it's not easy to follow the recovery from an acute attack of vestibular neuritis. And why video head impulse test allow us to test the patient in several locations, and the patient is happy to do that. Just like this lady tested 10 years ago at the time of that paper I mentioned it before, in July 2011, at the time of the attack. And if you can see, I tested her 1 year later with the same pattern of covert saccades. But at the time of 8th of May 2012, this patient was very happy. Why? There is a secret, probably, but we are trying to answer this secret, while in this occasion, probably the patient can use his saccades to substitute the gain of the VOR. But we learned so much, I say, as in this case, and we documented how it's possible to obtain the restitutio ad integrum, as you can see in this case.
Dr. Manzari, can you conclude?
Yes. I try to finish. So the last slide are for the otolytic region. These obviously are the bedside examination. We have two weapons, the cervical vamp and the ocular vamp, with the classical pattern of superior and superior, while the N10 under the contralateral eye is absent, and with superior and with the vestibular loss when total nerve is involved. N10 and CVAMP are absent. So thank you for your attention.
Thank you very much for the presentation. I have many questions, but I can ask you a couple. How important is the role of vestibular rehabilitation in vestibular neuritis?
How is important?
One word?
I think that vestibular rehabilitation is we need to be honest. Probably we need time to say we need vestibular rehabilitation after vestibular neuritis. In my mind, the first occasion is at the first time we saw the patient at the time of the attack. The first recommendation is move as fast as possible, and probably this is the best rehabilitation. When we check the patient in our clinic after 2 months and after 6 months, as I showed, we have a lot of information. And at that time, when probably the semicircular canal recovered while the otolytic system is not recovered, that time we have the answer to obtain an indication for vestibular rehabilitation.
Another question from India. Will you use steroids in patients with diabetes mellitus with acute vestibular neuritis?
Can you repeat the answer? Sorry.
The question, yes.
Yeah.
Will you use steroids in patients with diabetes mellitus with acute vestibular neuritis?
Can I show to answer this this question just a slide that I jump in the conclusion? Just one. Okay. Just to answer. Okay. This is crucial to me since I can answer in this way. I published this evidence in 2011 in Laryngoscope. A patient with diabetes, 82 years old woman, as you can see at the time of the attack here, clear superior vestibular neuritis, recovered 21 of March, 3 months later, without steroids, without any kind of steroids. This lady recovered the function of the horizontal semicircular canal, and this lady, 82 years old, diabetes, recovered very well the N10 under the contralateral eye. So without using steroids, it's possible to recover after vestibular neuritis, also in diabetes patient, to me.
Dr. Ardich?
Thank
Are
you
we
very
on
much.
time?
Yeah, just on time.
Yeah, I would like to thank all the panelists for the excellent information provided. And once again, thanks to Dr. Özgürgen for providing this opportunity to share with the world these important scientific knowledge in the days that we are closed in our homes. And I hand over to Dr. Ardich for final words. Thank you very much.
Thank you for all speakers. And now we have a 15 minutes break for the preparations of the next session. See you in the next session. Thank you.